Hello, everybody, and welcome. Thank you so much for joining us. I'm Josh Weber. I oversee the Youth and Juvenile Justice Program at the Council State Government's Justice Center. If you are not familiar with the Justice Center, we're a national nonpartisan nonprofit organization. We work with all branches of state government as well as local government to improve outcomes for youth and adults in the justice system. I'm excited to be joined by Dr. Gina Vincent and Dr. Jennifer Scheme, who are the primary researchers of the Youth Protective Factor study. And we're excited to be speaking with you today about the findings of the study. This webinar is the third in a series of webinars that we will review the methodology of our most recent findings, the key findings of the analysis, and recommendations from the recently released third brief in the series. And we will have time at the end for question and answers. So as Greg mentioned, there's a question and answer button at the bottom. Please feel free to add your questions along the way, and we will try to address as many of those at the end of the presentation. All of the previous briefs and the webinars are posted on our website as well as UMass's website. You can see the link on the title page. So we certainly encourage you to review all the briefs in the series because they all have different analyses and important recommendations and takeaways for the field. With that, we'll get started and I'll turn things over to Dr. Vincent.
Thank you, Josh, and good afternoon, everybody. Thank you for coming today. It's my pleasure to talk about the Youth Protective Factor Study, which is an unprecedented multi-state, multi-year examination of which risk and protective factors are most significant when it comes to reoffending among youth involved in the youth justice system from age 10 to 23. We were especially interested in serious offenses, and we also took a look at what services may be related to reductions in reoffending. And I do want to say, this was a Herculean effort between Dr. Scheme's lab and our lab at UMass Chan Medical School. And Josh is being very humble because he also was a co-investigator on this project and did the amazing task of rallying us research scientists and making us do what we need to get done, which is not easy. So thank you very much, Josh, for also participating in this with us. So I'm going to talk to you a bit about the main purpose of the Youth Protective Factor study. We're not talking about everything in this study that we did today. As Josh mentioned, we've already come out with two briefs that include different research results. But we recognize an overarching purpose of this project was the recognition that youth justice agencies' resources have been more and more limited ever since the COVID shutdown, in part because of just a mass exodus of service providers, in addition to just not having as many financial resources. Therefore, one of the overarching goals, as I mentioned, was to be able to examine questions that would help us to assist youth justice agencies with where to best put their limited resources that they have, both with respect to what youth should they be paying the most attention to, and with respect to service delivery in their case planning. And one of the pieces that we were interested in was positive youth development. So you may be familiar with positive youth development. That involves taking an intentional approach to engaging youth within their communities, enhancing their strengths, and promoting positive outcomes by providing opportunities and fostering positive relationships and creativity. This positive youth development approach has been very popular in educational and child welfare settings. In 2005, really, is around the time that it got brought into the youth justice arena and known as positive youth justice. At least that was the term coined by researcher Jeffrey Butts. And the study was designed in part to help answer several outstanding questions around how do we really best implement positive youth justice in a youth justice setting. We've reported findings related to that in our last brief and our last webinar, where we looked at what protective factors matter most and whether strengths-based services are having added value. Today, we're really going to talk about the other aspect of our study, which was to look at risk-need responsivity a bit more, which, as we know, is the dominant framework in justice settings right now, both in the youth side and the adult side. And this indicates, of course, as most of us probably know, that we should address youth's primary risk factors that have been getting them involved in the system to begin with. We should be addressing them by appropriate service delivery that's going to help reduce those risk factors, and it should be done in an individualized way. One of the large questions of the study was, how do we integrate the two? Do risk factors matter more, or do protective factors matter more? Or are there some risk factors that matter a lot and some protective factors that matter a lot? And so we really wanted to look at how do we integrate these approaches rather than seeing them as competing. And of course, the authors of Risk Need Responsivity do talk a fair bit about strengths and the need to cultivate strengths under the responsivity principle. So it's not completely new, the idea of incorporating strengths into this process. So for the overarching study, again, we had three primary goals. One was to build data tracking capacity in order to really look at what services are helping to reduce recidivism the most. The first thing that we had to do was help these youth justice agencies to greatly enhance the service data tracking that they were doing. I think for us who have been working a lot across the country, this is probably one of the ways in which most youth justice systems, case management systems, are limited, and that they're just not tracking a lot of services. So one of the things we had done with our states, which I'll get to in a moment, our states I'll describe in a moment, is to work with them to build capacity in their existing systems and to start tracking every service youth were receiving, regardless of the payer of that service or if the service was free. So that included even activities that the youth were getting from the schools, such as they're involved in sports or they have other extracurricular activities like tutoring or yearbook club. We also made sure that they entered all of the mental health counseling youth were receiving and services they may have been receiving from the child welfare system, so that we really had a robust data set to examine what services were going to make the most difference. Right, so that was step one. They also started tracking every service youth received when they went to a placement, whether it was a group home or a secure custody setting. So this is probably one of the most robust service data sets that I've seen coming out of the youth justice system. It enables us to answer a lot of questions. Our second goal, as we mentioned, as I was mentioning already, is that we wanted to identify the risk and protective factors and types of services that were most strongly associated with reoffending in order to help inform supervision strategies. And we are most interested in post-supervision reoffending. So what are youth doing after the youth justice system is completely done with them and they're no longer involved? We think that's the recidivism that we would be most concerned with, and that our agency partners were also most concerned with. So we're looking at longer range recidivism post any supervision in the system. And lastly, we wanted to look at those questions in goal 2 by age. So as I mentioned, our age group, it is wide. It is age 10 to 23. There are about 3 different developmental periods, at least, within that age group that the youth justice system is supposed to serve. There is reason to believe that there will be differences along that lifespan continuum. Well, it's not a full lifespan, but along that continuum around what protective factors are going to matter the most and influence youth the most, and what risk factors are going to influence them the most, and also what services are going to work. So for example, does cognitive behavioral therapy work with really young kids when their brains are operating slightly differently than a young adult? So these were some of the questions that we set out to answer. I'm not going to answer them all today. Dr. Scheme and I are not answering all of these today. We have answered a few of these in our past webinars, but I did want to give you all the scope of the project. So I'd like to do a big shout out to our state partners and talk to you all a little bit about the methods that we used in this study before we get into the results. So we had three state partners, Wisconsin, Virginia, and Pennsylvania. Thank you all very much if any of you are here for participating with us. This ended up being a much larger undertaking than any of us had imagined. We worked with the state agencies in each of those three states to identify 4 to 5 jurisdictions or counties within each of those states that we would work with for the prospective part of this study. We selected these states in part because we had prior relationships with them, and that is important, obviously, when you're engaging in a research partnership, but also because each of these three states was interested in adopting positive youth development or had already adopted positive youth development in some way, shape, or form. Each of these states had a validated risk needs assessment tool that they were already doing at an early stage in the process. So 2 of our states were doing it at probation intake or the point of referral, and 1 state was doing it post-disposition. Post-adjudication predisposition. So that was key, and all of these states agreed in these jurisdictions to administer a protective factor survey to every youth alongside that risk assessment that was already being done. That led to a good validated protective factor survey. Second, they were all interested in expanding their service data tracking capacity. They all had good statewide case management systems that were a strong starting point for us to work on that with them. And lastly, they all needed to have access to both juvenile and adult recidivism records in order for us to track recidivism longer term, which we define as new petitions, right? So we also looked at new adjudications. We are not presenting findings on new adjudications. The reason is, obviously, as probably many of you know, it takes longer to get adjudicated than it takes to get a new petition. If we had evidence that the petition was dismissed, we did not count it as recidivism. So these are all new petitions that presumably went on to be adjudications. A petition is closer in time to when the event actually occurred. So when the recidivism actually occurred, which is really important for us because we do a lot of survival analyses as researchers, and that timing as to when the youth engaged in a violent act is important. Okay, so that was a little bit about our methods. 3 states we did a lot of work with. Here's the research questions that Dr. Scheme and I are going to cover today. The first is, which risk factors were most strongly associated with serious recidivism post-supervision, and do these risk factors differ by age? Second is, which services are youth most commonly receiving in the system? And is the risk principle being followed by these youth justice systems? For those who may not be aware of what the risk principle is, that means the higher the risk you are for reoffending, the more services or the more supervision or the more attention you should be getting. The lower risk youth, we don't really want to do much with at all. So we wanted to see if the risk principle was really being followed. Third, Dr. Schema is going to talk about whether receipt of risk reduction services predicted lower recidivism post-supervision. So if youth got services that were designed to address a risk factor, is that actually leading to lower recidivism? So for example, we know some risk factors are certain aspects of the family and the family dynamic. Are the youth getting supervision in the home? Are they getting appropriate discipline in the home? Is there a lot of conflict in the home, and so on? We know that that is a risk factor area. A risk reduction service in that case would be something like parenting practices intervention, a home-based intervention, or something evidence-based like multisystemic therapy. Just to give you a sense of what we're talking about with regard to risk reduction services. And Dr. Scheme is going to give you the definition in a little more detail when we get to those research questions, the answer to those research questions. Okay. Here's our sample. So we worked with these states to gather new youth cases as they were coming into the system on a new offense. They had to be youth that were not already engaged with the system. So they were coming in on a new offense over a 13-month period where they were administering this protective factor survey, which again, we're not going to cover the results of that today, but those results can be found on our website. So it was a 13-month period. This generated a sample across those 3 states and 15 counties of over 3,000 youth. That's a pretty decent sized sample, uh, gathered prospectively for researchers in the room. And our 3 samples looked quite different across states. So we were originally intending to combine all the data across the 3 states into one sample and conduct analyses that way. But there were just too many differences that necessitated separate analyses by state. So everything that we've reported for most everything we've reported for the study, we've done by state. There's a couple big differences I want to point out to you right now. So state 1 was our largest sample. Had almost 1,300 kids in state 1. That means this was the best powered analyses were coming out of state 1. State 2 was a very small sample. It was so small that there are several analyses that we couldn't even do in this state. Another difference is that state 2, and this is the reason that we picked state 2, had a much younger age group on average. And we really wanted to get young kids in our sample because we were looking at developmental differences. So their kids were younger. Their kids who were getting referred to the court were younger. And the average age for the sample as a whole was around 15 and a half years old. Another detail to point out is that one of our states was administering their risk needs assessment post-adjudication predisposition. That's a little more serious group of youth than the group of youth who are coming in on a referral, like we saw in state 1 and state 2. Our samples started accumulating after the point of the risk assessment, was conducted. And so state 3 sample is a little bit more serious. So they had the highest percentage of high-risk kids, which was 22%. And consequently, their violent recidivism rate was higher than the other 2 states as well, hanging at 17% of their youth recidivating post-supervision with a violent offense. And we define violent offenses based on the research definition, which is essentially intentional or actual harm to another person. So that includes every type of assault in there. So not all of these violent offenses are extremely serious, but they are all reflecting harm or intentional harm to another individual. One more detail I want to point out really quickly is that also when we are presenting our results by state, which Dr. Scheme is going to do, we mixed these up. So the picture I showed you before, the order of the states is not necessarily state 1, state 2, and state 3. We promised the states we would de-identify them in any of our analyses. So this doesn't necessarily correspond with which state with Pennsylvania, Wisconsin, and Virginia. They're jumbled intentionally. So all right. One other thing that I forgot to mention, the largest percentage of our sample was Black. They're about 45% of the overall sample was Black youth. And of course, the majority of the sample is male, which is always the case in youth justice setting. So I'm going to launch into the first finding. One significant finding, which I want to mention that this study also included a very large retrospective sample of over 20,000 kids. Maybe it was over 30,000 kids. I can't recall right now. Our first brief had a much larger sample from these states, and it found the same thing, relatively the same thing that I'm showing you here from our prospective sample. And that is that it is still the case, a significant portion of youth getting referred to the youth justice system are low risk. So even though the system knows a lot about risk need responsivity, and we all know a lot about how interfering with low risk youth lives is certainly not cost effective, but also not leading to any great outcomes. Even though many of us know that, it is still the case that the majority of a significant proportion of youth getting referred to these systems are low risk. So here's what our sample looks like overall across all 3 states. On the left side there, you see their risk levels. So 43% of the sample was low risk, which is the largest percentage. 37% were moderate risk, and only 11% of the youth getting referred to the system. And by the way, this includes that post-adjudication sample from state 3. Only a very small percentage of youth getting referred to the system are high risk. That's to be expected, just statistically speaking, because high risk youth are the least common. They're the least common youth in the community in general. But one question is, why are all of these youth still getting, all of these low risk youth, and 80% of them were first time offenders, why are they still getting referred to the system? So 54% of these youth referred to the system, and 62% of the low risk youth specifically did not get any services. So again, there doesn't seem to be much benefit of referring them to the system. What is one great finding, I think, is that our 3 states that we partnered with, our 3 state partners, were all pretty much following the risk principle with respect to how they were managing dispositions for these youth. So as you see, a pretty decent chunk of these youth were basically just sent home, counsel and close. They had no sanction. Their charges were dismissed, or they got a counsel and close. So that's good. The majority of those youth were low risk. A few of those were high risk youth, so that's a bit of an issue. But 35% were handled informally or diverted. So by informally, we mean some kind of deferred prosecution or informal adjustment, or they were diverted. Most of that chunk of youth did not get any services. About 40% of our youth ended up on community supervision at disposition, and less than 4% were given a disposition of going to a secure custody setting or group home or other sort of placement. Less than 4%. That's an initial disposition, otherwise known as sentencing if you're from the adult system. 25% of these youth eventually ended up in a placement at some point due to a violation of some sort. So not a huge chunk. All right. Also, I should just mention that a very small percentage of low-risk youth in our sample, 10%, actually got a new petition for a new offense during our follow-up period. So again, there's not a lot of benefit to bringing them into the system. They're not getting services. A very small percentage, as we know, reoffend, and their offenses were primarily very minor offenses. Okay. Finding 2. Some risk factors predict violent reoffending more strongly than others and should be prioritized for service delivery. This is a really exciting part of the study for me, because we do a lot of work with probation offices around case planning, case management, and judges to tell them what risk factors matter the most. And what we found here was pretty similar to what we found in our retrospective, our large retrospective sample. So we have a pretty robust result here. So I'm going to break this down a little bit and try to make it as not confusing as possible. There is a measurement difference here. So if you're using the YLS or you're using the YAZI, there are some slight differences in what risk factors or risk domains matter the most, depending on the instrument that you're using to assess risk. For the YLS, what mattered the most was the personality behavior area. And again, for those who aren't familiar with the YLS, that is containing things like poor anger control, attention issues, inflated self-esteem, and lack of remorse. So a lot of those things that if we saw them in adults, we would consider them to be personality traits, but we see them in youth, they're more disruptive behaviors. For the YAZI, the most important area was the family domain. Okay, and the reason I'm lifting these up is that these risk domains actually stood above or rose above the other risk domains with respect to the strength of their association with later post-supervision recidivism. It is also the case that there was some consistency here, and that the YAZI's violent and aggression area violence and aggression area, which is very comparable to the personality behavior domain, was a significant predictor of violent recidivism post-supervision. And on the YLS family area, family circumstances also was a significant predictor. So these are significant predictors on both tools. It's just what mattered the most depends on the tool that you use. There are other predictors, very significant predictors of violent recidivism post-supervision that were consistent between both instruments. It's just the one domain that mattered the most was not consistent. Where there was consistency, education and school problems. And again, both instruments define education and school problems largely based on behaviors in school, truancy, getting in trouble with teachers, getting in trouble with peers, getting expelled. There's only a small number of there's only a small bit of that measurement that has to do with actual school performance. So school problems are probably largely related to that personality behavior domain anyway. Also peer association, so who they're hanging out with, who's their influence. Those were also a very robust predictor of violent recidivism post-supervision. And on the YLS, attitudes that support crime was also a robust predictor of later recidivism. It was not on the YASI, and we think that's mostly because the inter-rater reliability for that domain on the YASI was not great in our data. So these are the ones that matter the most. They actually are the majority. These actually list most of the risk domains in both of these instruments. So if you are a probation officer, if you are a judge, if you are responsible at all for the supervision of youth involved in the youth justice system, the point here is to try and guide what you prioritize with respect to service allocation. So what is it that is really the top one or two areas that you want to make sure are getting addressed if the youth is scoring moderate to high in any of these domains? Because if you have a high risk youth, we can't address everything at the same time. That's just not feasible, and it's not going to work for the youth either. So when we're prioritizing, here's the list that you might want to think about prioritizing. Another very interesting finding, contrary to our hypotheses, was that all of those risk factors that I just showed you were robust and significant predictors of later post-supervision violent recidivism, regardless of the youth's age. And of course, in all those analyses, we controlled for gender and race. Okay, so, but also age. So regardless of the youth's age, they weren't moderated by age effects. So that means if you're working with a 12 or 13-year-old, these are still the areas that matter. And if you're working with a 23-year-old, they're still the areas that matter. We only had one risk domain that really had strong, significant age moderation effects, and that is substance use. And what's so interesting about this to me is that we not only found that here in this prospective data set, we also found it in the retrospective data set. That compels Dr. Scheme and I, who I'm going to talk for just a second, to both argue that this is a really robust finding that we probably want to start integrating into case planning in some way. So what is the finding? Let me explain what this means. Substance use, what this graph is showing us, this is a predictive survival probability graph. And what it's showing us is as substance use risk scores get higher, doesn't matter if you're using the YASI or the YLS, as the substance use risk score gets higher, for younger youth, the likelihood of violently recidivating post-supervision is going up. And the younger youth is that green line there. As the line is decreasing, that means they are recidivating. So for that younger group, there's a significant effect here of substance use risk on later recidivism. But if you look at that purple line, which are basically our young adults, substance use in this sample, substance use risk was really not particularly predictive of later violent recidivism, or was a very weak predictor of later violent recidivism. And even for the middle adolescent group, or for those in the middle of the age range that we were studying, it's a pretty weak predictor of violent recidivism. So the take-home message here is that when deciding whether to target substance use in case planning or whether to give substance use treatment for youth involved in youth justice, if the interest is protecting public safety, you probably want to put more attention on that for the younger kids where it's less common for them to be engaging in a lot of substance use. The younger kids, it's just not as common as it is with older kids, older adolescents, and young adults, where there's a lot more experimentation and so on. Supervision practices such as a lot of drug testing and so on may not be particularly helpful for these older kids and young adults, whereas you may want to focus attention on that for the younger ones. Okay, so, and we'll cover the implications again in a moment. I'm going to pass it on now to my colleague, Dr. Scheme, who's going to go over the last two findings.
Thanks, Dr. Vincent, and hello, everyone. I'll see if I can transition screens pretty quickly. All right. So I'm going to present the last two findings that are focused on in this brief, and they have to do with the services that were provided and also the impact of those services on reoffending. Now that we've gotten a better understanding of who these youth are and which risk factors are really most predictive of reoffending, we're shifting now to take a look at services and their impact. So our third finding is that higher risk youth did not consistently receive the amount, type, or quality of services that are really required to prevent reoffending. So even though we saw earlier that the system seemed to be performing pretty well in terms of mostly diverting lower risk youth from the system altogether, when it comes to service and service matching, there's definitely room for improvement. So we took great care, and by we, I mean mostly Dr. Vincent and her very highly trained staff, in working with these agencies to really increase not only the amount of services that they were capturing, that was the first task, but we also spent a great deal of time classifying the kinds of services that were being provided in the real world out in these states. We got the input of three experts, one expert in risk type approaches, another in protective or strengths type approaches, and another who really is just an expert on youth development generally and associated with blueprints. We worked with them to develop a system for classifying the focus of these services. So we took this huge, massive database of services and then classified each service based on its target, basically. So they're one of three options for this. The first type of service that could be coded is one that really was focused on reducing risk. So this is classic R&R type approaches where what we're trying to do is reduce risk factors, ideally some of the risk factors that we just saw that matter. So we're trying to treat dynamic risk factors or criminogenic needs and really focusing on that in an effort to prevent reoffending. So these are really about reducing risk factors to prevent recidivism. So examples of this would be, you know, the bread and butter evidence-based practice in a lot of the literature is cognitive behavioral treatment that's really meant to loosen some of those attitudes that can be supportive of crime, help people develop better self-control. So it helps get at some of those personality and other strong risk factors that we saw earlier. It also can help with some of the peer associations that can be problematic. So CBT is a prototype, but there are other services that you can see here that are also meant to target risk factors for recidivism to prevent it. So family services, we saw that family risk factors were important in this study. So there are evidence-based package programs like multi-systemic therapy, functional family therapy, parent management training, but also things that are much more commonly provided in the community like substance abuse treatment, substance abuse is a risk factor, especially for our younger people. So you can see that there are a number of examples here. One that will come up a little bit later that I do want to highlight here is EPICS, which is really not so much an individual focused program as much as a training approach for probation officers that really helps them learn to focus on implementing risk need responsivity principles. So try to establish firm, fair, caring relationships with supervisees, target criminogenic needs, and really prioritize higher risk cases. So that was the first bucket, is risk reduction. The second was strengths-based approaches. Again, one of the most unique features of this big study was its deliberate focus on strengths, measuring strengths with a protective factor survey, and also really getting serious about coding strengths-based services. So this is a different focus. The goal here is less to reduce reoffending risk than to promote positive youth development. So what these are designed to do, or could do, is promote competence, the development of competence and skills for transitioning from adolescence to successful pro-social adulthood, building pro-social engagements with peers and with adults, or other kinds of pro-social attachments that are really just part of healthy development. Examples here that we saw when we were coding the services provided include things like Big Brothers, Big Sisters programs out in the community, school-based sports programs or other kinds of programs, volunteer work, and pro-social skills or life skills training would actually be an evidence-based type approach in the strengths bucket. The final bucket or service type that we could code services as are responsivity-related services. So these are not designed necessarily to prevent recidivism, except as an adjunct to the risk reduction type services. So the second R in the risk need responsivity model is responsivity. And the idea here is this has to do a lot with whether you're providing treatment in a way that is responsive to people's learning styles and also some of their individual characteristics that could promote the effectiveness of other types of programs. An example here is mental health counseling, which by itself doesn't prevent reoffending, but in theory, if you address people's mental health needs, they may be better able to engage in, for example, cognitive behavioral treatment that targets risk factors. Also, services like culture-specific services or gender-specific services that are really addressing the unique needs of who youth are in the way that they provide services. Special education or highly structured delivery approaches is another way of delivering treatment in a way that's responsive and will have higher impact in theory. So those are the three buckets we coded the services in. So again, it's risk reduction, strengths-based, or responsivity related. So first, shifting to findings and returning to our high level finding number 3, what we found is that the services that were provided tended to focus much more on responsivity than reducing risk. So what you can see here is the dosage units per month of supervision. This is basically a shorthand for putting everything in one common metric that tells us about how many units of different types of services did they get per month. And what you can see is that it's a bit less than 5 units on average for risk reduction services across all the sites, compared to nearly 5 times that amount for responsivity type services per month. The prototype, as you'll see in a moment, for responsivity services was mental health counseling. I've mentioned this, but we know from a number of studies that mental health and responsivity services don't prevent reoffending on their own. To prevent reoffending, systems really have to provide services that are purpose-built to reduce risk. The disheartening finding is that this was true, this lack of balance between risk reduction and responsivity services, even for youth in placement. So even for youth who were in relatively high intensity settings, who were getting a lot of services, those services were not necessarily intended to reduce their risk. That wasn't their ultimate goal. Mental health counseling is not designed to prevent recidivism. It's built for another purpose. So what we found is that even for those in placement who are arguably higher risk as a group, we're not more likely to get risk reduction services than those who were on probation or less restrictive dispositions. Let me just make sure I'm not forgetting anything here. Okay. Following up on that theme, when we look at the kinds of risk reduction services, right? So we're just zooming in on the red bar now. We're looking at the provision of services that are designed to prevent recidivism, and we're binning that by whether youth were classified on these standardized risk assessment tools as low risk for reoffending, medium, or high risk. And what you can see here is that there's a nice differentiation between low and everybody else, right? So lower risk youth were less likely to get risk reduction services, which is good because they're at low risk for reoffending. But there was no statistically significant difference between the likelihood that that small group of people at really high risk for reoffending were not getting significantly more services than the much larger pool of those who were only at moderate risk for reoffending. So the risk principle, in essence, wasn't followed. We really want to prioritize those precious risk-reducing services for the ones who need them the most and really try to deliver as much dose as possible so that they can benefit through prevention of reoffending. So we classified these services not just based on what their targets were. Are their targets to reduce risk? Are their targets to build strengths, which we report in brief too, by the way? Or were their targets to deliver services in a way that was responsive to other features, like maybe non-criminogenic needs like mental health? The other way that we coded services was just kind of based on their types. And this is pretty specific types. So what you're seeing here is just the 5 top categories of services that were provided across settings. So if we're just interested in what were youth most commonly getting, if we strip away their targets for a second and just focus on labels, you can see that it's a variety of things, but really the 800-pound gorilla, the thing that accounts for 1/3 of all services, is mental health counseling. So again, this is a responsivity service that's not designed to reduce risk, and that's by far the most common type of service that was provided. One of the next most common types was work placement. This is really classified in our other system as a strengths-based service. Which is theoretically important, but there actually isn't a lot of strong research evidence that vocational type services are particularly good at preventing reoffending either. If you want to think about this as glass half full, you can be happy about the fact that almost half of the pie is red, which means that these were all classified. The next 3 most common services were all classified as risk reduction services. So that's a happier situation. The problem is that they're not necessarily the risk reduction services that we would hope for if what we wanted to do was target those really robust risk factors that Dr. Vincent presented earlier. So we don't see anything like functional family therapy or parent management training or other sorts of services that would really target the family factors. We don't see CBT, which we know is pretty good at getting at some of the personality, impulsivity, attitudinal, or peer type factors. Instead, what we see as the most common ones are victim empathy training, which was about 19% of cases. This is kind of a relatively short didactic type curriculum that focuses on building empathy for victims, but doesn't include the kind of mediation meetings with victims that would be part of restorative justice. So 19% victim empathy training, 18% ethics. Again, that's the training for correctional officers to implement risk need responsivity, and 13% drug and alcohol counseling or substance abuse counseling, which was really only a risk factor in our sample for the youngest kids. So with the exception of ethics, which is classified as promising, for reducing recidivism, we're not really seeing good representation here of what we would hope to see in terms of risk reduction services that could really make a difference, especially for our higher risk cases. Although states varied, this isn't reported in the graph, it was really on average only about 15% of services in states that could be classified as evidence-based, like CBT or FFT. And one of the things that we learned anecdotally, sharing findings with the sites about this sort of disconnect between what youth needed and what youth got, was a response that really mental health counseling is what is available in our communities. So that's what we got, even though we would have preferred to have really great risk reducing services for our higher risk youth. We referred to them to what was available in the community, which is really just mental health. And it's kind of important to recognize that that is a signal that it's important to partner across systems to really strategically find ways to fund evidence-based risk reduction services that really do need to be prioritized for our higher risk youth. So leaders could convene juvenile justice and family service systems to assess exactly these kinds of service gaps and coordinate funding, Medicaid and other, to address some of these mismatches so that things like CBT, for example, could even be offered in-house. And that's an implication that Josh Weber will develop a little bit later. I want to shift to our second, well, this is really our last finding. So this shifts from describing the types of services that young people got and how well, at least at the group-based level, those services seem to match or really not match the most common risk factors we're seeing and didn't seem to really target the highest risk people. Now we're shifting to basically what is the impact of risk-based services? And the disheartening finding, which may be a little bit easier to wrap your head around having seen what the risk reduction services look like, is that youth who did take part in risk-based services were no less likely to reoffend than youth who did not participate in such services. So even though we could classify those services as risk-based, given what they really were, they weren't especially effective. So what you're going to see here is a report of our findings at the state level, because again, states varied. State 2 didn't have sufficient service data for us to look at it individually, but state 1 is shown here in gray. This was our biggest state and the best powered state. State 3 is smaller. What we did, this is just an observational study. So we tried to do our best to use statistical controls and machine learning to control for variables that we know would be associated with the likelihood that youth would get risk-based services, including how at risk they were, their demographics, their socioeconomic status. We controlled for a variety of those factors that can relate both to a higher likelihood that somebody will get a risk reduction service and also the likelihood that they actually reoffend. So these analyses do our best to control for some of those characteristics of youth. And what we can see, this shows you the hazard ratio, like how likely it is that the youth was to reoffend, either have any reoffending post-supervision or to have violent reoffending post-supervision. 1 would mean there was, in essence, no effect of the services on the likelihood of recidivism. What we can see, unfortunately, is that in state 1, if anything, those who participated in risk-based services were a bit more likely to reoffend than those who did not. So this would be about it's a 1.75. Even though this also is in the wrong direction, so violent recidivism is in the wrong direction, this is not statistically significant. You do not see stars on any other bars here, which basically means that we don't see any significant relationship in state 3 and for state 1 for violent recidivism between participation in risk reduction service and the likelihood of reoffending. We did a lot of pressure testing of this finding because it was counterintuitive. And we'll tell you that we see the same pattern of results when we use alternative techniques for sample weighting or statistical analysis. We also see the same basic effects when we exclude youth who spent any time in placement versus those who didn't. And we also see the same pattern when we're really looking not just at whether anybody got at least one service, but also if we try to get more specific about what dose of service they received. So the bottom line is that youth who participated in these services were either more or as likely to reoffend post-supervision than youth who did not. And hopefully you're approaching this finding with an understanding that the risk reduction focused services were not ideal as practiced out in these states. So that really, I think, is the more important lesson here necessarily than this one. And we also are taking deeper dives to do even better analyses that help us understand more the causal relationship between risk reduction and other kinds of services in the study and recidivism. So there's more to come here, but the descriptive findings will stay the same as finding 3. All right, with that, I'm going to pass the baton to Josh Weber.
Thank you, Dr. Scheme. And if you want to go to the next slide, want to share some key implications of the study, building off what Dr. Scheme and Dr. Vincent said. And then there's a lot of good questions in the chat that we want to get to, particularly around how services were classified and the difference between mental health and risk reduction services. So first key implication to really emphasize, and so I'll comment about this in the chat, is around diversion, and particularly looking at not just pre-court diversion, but pre-arrest diversion. There's robust research at this point that shows that the decision to involve young people in the juvenile justice system versus diverting them can negatively impact the entire course of their life. That youth who are formally processed by the juvenile justice system compared to youth who are diverted are more likely to be arrested, more likely to be incarcerated, more likely to commit violence, less likely to go to school than youth who are diverted. And our study adds to this existing research in important ways. As Dr. Vincent showed, over 40% of all youth who were being referred to the system were low risk. Over half of those were diverted at intake with no supervision or services, and we know that nationally, 70% of all youth who are referred to court are not adjudicated. And then really the unique contribution, I think in particular, of our study showed that many of the youth, 2/3 of the low-risk youth, didn't receive any services. And despite that fact, very few reoffended up to 2 years post-system supervision, and even fewer committed a serious offense. So it really raises the question around the benefits of referring so many of these young people to court in the first place. We hear in many jurisdictions that youth are often referred to the juvenile justice system, not because they're a public safety risk, but in order to get them services. But based on our findings, what we found is that many of those youth aren't getting any services. And if lower risk youth actually need services to address non-criminogenic needs, like mental health or housing or a learning disability, folks had questions about all of those in the chat, then sending them to the juvenile justice system might actually reduce their chances of getting those services, because those cases are often diverted or dismissed with no further involvement from anyone. So in a time where there's increasing concerns around youth crime and youth violence, if you care about public safety, if you care about kids' mental health, their education, if you want to ensure public resources are being used efficiently, if you want to ensure resources are focused on the highest risk kids who are at risk of violence, then state and local leaders should really require pre-court diversion and establish jurisdiction-wide pathways to services. That could be through alternative response models that instead of the police being involved, could be mobile crisis, could be social workers, could be family resource centers. There are states that have statewide civil citation programs for lower risk youth that instead of getting arrested, they get assessed and referred to services. Some states have local youth service bureaus. There's a growing movement around assessment centers. So there are a lot of options here, but our study really emphasizes the need to develop pathways outside of the juvenile justice system to be more efficient and effective with this low risk population. Second key implication, and Dr. Scheme and Dr. Vincent both talked about this, is really the importance of getting back to basics and focusing on risk-need responsivity. Risk-need responsivity really is the foundation of what research has shown works to reduce recidivism for the last 3 decades. But our study highlighted that states and local jurisdictions are still struggling to implement R&R in practice. This was true for all 3 states in the study and is true for just about every state that we work with, which is many states across the country. Our research showed that the different risk tools used by states were predictive of not just during system supervision reoffending, but post-system supervision about 1.5 years on average afterwards. So it really emphasizes the importance of using risk and need screening tools to guide diversion decisions, dispositional decisions, and supervision and service decisions. But we also found that while those tools were correctly identifying youth were higher risk to reoffend, as Dr. Scheme and Dr. Vincent talked about, the highest risk youth were not being prioritized for services and were not necessarily receiving the dosage of services needed to reduce their risk of reoffending. And more generally, and you can see more details about this in the brief, it wasn't clear that for youth of all risk levels, that there was a clear and consistent match around those young people's needs and the services they received. In particular, the study highlights the importance of personality attitudes and family functioning and negative peers as key drivers of long-term serious reoffending. Yet prior research, including from Dr. Vincent, has shown that these are the dynamic risk factors that youth are often the least likely to receive services around. And instead, youth are often more commonly receiving services such as substance use services that our research showed actually substance use matters the least for serious long-term reoffending except for younger youth. So I think the real takeaway here is that jurisdictions really need to focus on the basics around risk need responsivity, around policy development, around training, around protocols in place to really be focusing on those higher risk kids once they're under system supervision. And this is especially the case given that many public agencies and public systems have experienced very significant staff turnover over the last couple of years. And so there may be a real need for jurisdictions to invest in significant training and reorienting folks around a common vision that is based on risk need responsivity. Another clear implication of our work is just the importance of not having a cookie cutter approach. And that really the key to long-term recidivism reduction is matching the right youth to the right level of supervision and the right services based on their individualized risks, needs, and responsivity factors. But much of juvenile justice system policy and practice is not based on an individualized approach. Youth have standard probation conditions that are often misaligned with their risks and needs and the case planning and service focus for youth, both on supervision and in placement. Many jurisdictions still have uniform case contacts for all kids on probation. All youth are drug tested. They all may have the same court review procedures, or lengths of supervision might be standardized, like 12 months or 18 months in placement or on probation. And often those standardized approaches are supposed to be done to make things easier and more efficient for the system. But I think what our study raises is it's not actually the most efficient and effective way of doing things in practice. And so really encouraging jurisdictions to rethink things like standard probation conditions or standard service orders or just standard approaches to especially higher risk kids in general. And it also stresses the importance of that the juvenile justice agencies can't do this work alone. that courts and attorneys and law enforcement and providers all need to have a shared vision around that individualized approach and the risk need responsivity model. Next slide. Jen, if you want to advance the slides. And so the next set of implications is really around services. And I think this is probably amongst the most important takeaways of the study. And obviously, as Dr. Skeeter, important but disappointing takeaway from both this analysis as well as the analysis that we went over in our last webinar around strength-based services was that youth who received services were not necessarily better off, whether those were strength-based services or risk reduction services, than youth who did not receive any services. And in fact, for both types of services in some of the states, as we've talked about, youth who received services actually had a higher rate of reoffending than youth who didn't receive those services. I think it's really important to say, especially in this political environment, this doesn't mean that nothing works. We actually have a lot of evidence, and more evidence than ever before, about what does work. That includes brand name kind of evidence-based programs like multisystemic therapy and functional family therapy and dialectical behavioral therapy. But it also includes more generic interventions like general cognitive behavioral therapy and family therapy, and more just generally a risk need responsivity service approach, and also growing evidence around practices like restorative justice and credible messengers. I think the real takeaway from the study is not that nothing works, it's that jurisdictions really have to do a lot more to align and strengthen their service systems with these best practice R&R principles and evidence-based programs. And first and foremost, we have to acknowledge that you can have the best trained staff in the world, you can have R&R based policies, but if there are no services, let alone evidence-based practices in your community, then it's very hard to do good service matching to focus on risk reduction services to make sure services are evidence-based, particularly in rural communities. And so really this requires the juvenile justice system partnering with the mental health system, with the child welfare system, the education system, effectively leveraging Medicaid, Family First, state funding streams to really coordinate efforts to build provider capacity and experience and expertise around the specific programs and services that justice-involved youth need. Because I think another clear takeaway is not just enough to have any services, they have to be the right services, and particularly a focus on risk reduction services. And what we heard from our state partners and what we hear in many states is other systems don't necessarily understand the unique needs of justice-involved youth and the importance of risk reduction services, which are different than general mental health counseling or other types of services. And so that means a real commitment to fund those types of models, to potentially have higher rates, to support providers to work with a higher risk population, to provide training in risk need responsivity and evidence-based approaches, and to really work together with other systems to ensure that those services are effective. Third, obviously, if the service system supports it, it's just, again, an emphasis on jurisdictions establishing R&R-based policies and practices to connect and match the right kids to those services. So that's assessment fidelity, it's case planning tools, it's case planning processes like youth family team meetings that can focus on barriers to service engagement. It's training for judges to not order services for kids until their dynamic risk factors are really known. It's an emphasis on quality assurance and data collection to track in real time service matching and dosage, service utilization, completion rates, and outcomes. And this includes placement. Important finding that kids in placement were receiving more responsivity services than risk reduction services, when the whole point of placement, which we know, generally is not as effective as community-based services, is to reduce high-risk kids' risk. But if they're not getting risk reduction services in placement, then placement very expensive, is not actually serving its primary purpose. So really an emphasis on spending a lot more time, energy, and investment in quality assurance and data collection, and then really using that data to drive service delivery and resource allocation decisions. Okay. With that, we'll start taking some questions. Jen, you can stop screen sharing. And there were a lot of questions that I was monitoring in the chat on how services were classified, and particularly this issue of how to tease out the difference between mental health counseling and risk reduction services, especially around cognitive behavioral therapy and family therapy. Where do cultural services fit in? Where do religious services, restorative practices services fit in? So Dr. Vincent, if you want to start and talk about how we tried to classify and tease out some of those distinctions.
Yes, thank you, Josh, for asking me that, because I was noticing a lot of those questions in the chat too. Excellent questions. We get that a lot. So if it was an MST or FFT type program, which we know is a variant of CBT, there are only a handful of providers that offer that in each of these states. All right, that's not widely available, and it's very clear to probation that they are referring someone to MST or FFT, and that is how the data would have been entered in their case management system. So all of the probation officers were trained and given a list of service types that they would be entering, and they had other one-off things that, you know, were idiosyncratic to the states that they also entered. And then we would go back and even ask them questions to make sure that this meant to be MST, was this meant to be FFT? But it's very clear when they're sending someone to MST or FFT. I think the bigger question is it possible that someone's getting individual counseling and that is in fact CBT? I think in our world, the individual counseling is generally talk therapy, or it's generic, or it may be a therapist who's occasionally applying CBT or DBT principles, but they're not going through the manualized CBT. More often than not, that's not what they're doing. So if a probation officer was referring someone to a clinician who is doing CBT, that is what they would have entered in their service data. I can say even among the individuals who went to a placement, so like a secure facility or an institution designed for behavior change, the most common service they were getting was generic mental health counseling and not CBT. They did have risk reduction types of programs and services that were CBT based, and that was coded separately in our data. I hope that helps. Jen, I don't know if you have anything to add, but that's how we determined. Yeah.
I think that's very helpful. I also think that, I saw sort of a discouraging, disheartening temperature in the comments, which is sad. It's sad but true. And I guess the most important thing to say is I think that these results may feel counterintuitive, partly because our brains are trained to process the label risk reduction as evidence-based. Mm-hmm. And what I really want to underscore 3 times is that is just a descriptive label of what the target of a service that was provided out in the wild was. So based on the kind of conversations that Dr. Vincent described having with practitioners on the front lines, you know, when there were wobblers or it wasn't clear which category something should go in, the focus always came back to what are they trying to accomplish with this service. So our label risk reduction service just means that it is a service that got placed into that category. It's designed to prevent reoffending, rather than it is strengths building or it's responsivity focused. So there's nothing about it that says that it's evidence-based. It's just about what the ostensible target was. The one other thing to say is that there are some positive findings in here, but setting that aside for just a moment, This is not a new, this is a really important finding. It's really important, and it's new for the juvenile justice system. I don't think there are many studies, if any studies, that have taken such pains to really code services in this way and as completely as they have been coded. So it's really important. And this finding, though discouraging, is consistent with a much bigger body of research conducted with adults and youth, which tells us that there's a chasm between like what we know works and what we study in research and what happens out in the field. So it takes effort and a lot of attention to fidelity and making sure that we're doing things the way that they were intended, to really implement even the evidence-based pieces of this in a way that we know would translate to reduced reoffending. And I'll just, like, one last thing is that the other, like, there's lots of great room for growth, and we're doing some things well, like diversion of young, lower risk people from the system. Now, I would say if we can just really get better risk reduction services in the system and then get the higher risk youth to them, that would be the second biggest gain to be had here. Like this is an opportunity finding venture.
Yeah.
I just,
I'll just add to that a little bit, and obviously see all the questions in the chat, and we really appreciate folks' interest. We won't be able to get to all of them during the webinar. We'll try to follow up. Many of the questions are answered in the previous briefs and in this brief, so would really encourage folks to review all 3 briefs. But I want to highlight something important that I think Dr. Skeen said, which is other than placement facilities and really just correctional facilities, it's very rare in a state or a local system to have an intentional service system designed for justice-involved kids. And our state participants really reinforced that the services that they were sending kids to was whatever services that were available in the community, and those were often mental health counseling services that were funded by the mental health system and were not specifically designed or trained or supported for justice-involved youth, and there was no joint efforts around risk need responsivity and what that kind of model looks like. And so I think what a lot of our findings are suggesting is that there needs to be a lot more intentionality around the development of risk reduction services and evidence-based practices and protocols that are specifically designed to address the key risk factors that this study highlights, correlates with long-term reoffending. And that's often because juvenile justice systems don't have a lot of dedicated resources. Most of the resources are Medicaid or some Family First funding. So it really emphasizes the importance of the juvenile justice system partnering with those other systems to say, yes, justice-involved kids have some similarities with kids that interact with those other systems, but they also have unique needs and they need specific types of services. And we need to design services, especially for that higher risk group of kids, that actually work effectively for this population. Saying a little bit on this front, a number of questions about how do you track these services and what does that data system look like, and were we able to track things like trauma or lengths of stay or just a whole bunch of education. So again, Dr. Vincent, I think it would be helpful if you could share how we supported states around data tracking and any lessons learned for jurisdictions about steps they should take in that direction.
yeah, just thank you, Josh. So just a quick note that there were a number of questions around did we control for length of stay or length of supervision or what have you. I want to make the point that everything we have presented, that our recidivism analyses used our gold standard methods of survival analyses, where we were only looking at recidivism over during time at risk, during use time at risk. So it factored out any time spent in a secure facility or a placement. And, we tracked that over time. Some kids only had 2 months opportunity to reoffend. Some had 6 months to a year and a half. So that was all balanced out in all of these analyses that we presented. When it came to data tracking, Um, like I said, the probation officers were all trained. They were given guides around how to enter services. We made drop-down menus in some of their systems so that they were entering the right kinds of services, and we got their data every 3 months from every state. And a very robust research team went through all their data and did quality assurance and went back to every probation officer to ask the questions if something was missing or something was not well understood. So it was, it was a very robust effort. And then there is a technical report for this that will be online from National Institute of Justice at some point, which has an appendix of the services that youth were getting in every state.
Yeah.
So that you can see that as well.
A lot of work involved, but I think a really critical takeaway is we found that the states that we worked with were generally not tracking services nearly at the detail required to actually measure the kinds of outcomes that we've looked at. And a lot of work was needed to get states to that place. But, again, a clear takeaway from the study is services really matter. And we can't assume that just because kids are getting services, either strength-based services or risk reduction services, that they're better off. So a first place to start for jurisdictions is to ask, are you able to track what services kids are getting? Do you know what those service types are? Do you know what the dosage is? Do you know if they're completing those services so that you can be doing these kinds of analyses or at least some level of service analysis for yourselves? And given that we know services are the key to recidivism reduction, it's certainly a priority place to start. So with that, I think we are past our time. Again, we really appreciate everyone's interest and engagement. We will try to answer the questions afterwards, and the slides and the recording of the webinar will be posted in the next few days. So thank you, Dr. Scheme, Dr. Vincent, and we appreciate everyone's time.
Thank you. Thanks, everybody.